Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Tom Martin, professor of medicine, one of the leading voices in multiple myeloma in the United States and across the globe. He's associate chief of hematology and oncology, professor of medicine at UCSF, one of the larger myeloma programs in the country. And today we're going to talk about how findings from the Pegasus and Iskia trials that were presented at the ASH 2023 meeting are influencing his choice of therapy for patients with transplant-eligible multiple myeloma. So welcome, Tom.
Hi, Ravi. Nice to talk with you.
So Tom, I guess we'll start off with the Perseus study. I know that we had the Griffin study before this, but the Perseus is the first randomized trial for the four-drug regimen of daratumumab, Velcade, Revlimid, and Decadron. And so for the audience who's not too familiar with this, could you just give us a little idea about the trial and then trial design, and then we'll talk about the results?
Sure. So this actually came off the heels of the Griffin trial, which was a randomized phase 2 trial, which actually tested the 4-drug versus 3-drug. The 3 drugs were VRD, and the 4th drug was daratumumab. So half the people just got VRD, and the other half got dara-VRD. It was a positive trial, and thus led to this Perseus trial. And this is the phase 3 that I think seals the deal for 4-drug combination as induction therapy. Now, this study, when it was planned, actually was randomized 4 drugs, dara-VRD versus VRD, in the transplant-eligible, newly diagnosed multiple myeloma population. And so these guys are age 18 to 70. This is a global study. So, in the US, we go up to 75, sometimes a little older for transplant, but this included patients 18 to 70, and they had to have good performance status and good organ function. Now, this study randomized patients, right up front to the 4-drug regimen, dara-VRD versus VRD. All the patients then went on to transplant, and then they went on to receive a couple cycles, 2 cycles of consolidation-based therapy. If you were in the VRD arm, you got 2 cycles of VRD. If you're in the dara-VRD arm, you got 2 cycles of dara-VRD. And then they went on to maintenance-based therapy. In the VRD arm, Revlimid until progression. That's standard of care for us right now for the newly diagnosed patients. And in the experimental arm, it was dara and lenalidomide. The dara was given monthly. After 2 years of therapy, if they were MRD negative based on a bone marrow biopsy, they could come off the daratumumab and just continue on with lenalidomide. If they were MRD positive, then they continued daratumumab and lenalidomide until progression. And so this is a very large, phase 3 study that I think, again, seals the deal. We'll talk about the data in a second.
So, yep, that's the demographics. So who were the patients who were treated?
So again, these were a standard newly diagnosed transplant eligible population. So the median age was younger than the average age of patients with multiple myeloma. So right around the 60 age range. But there was a kind of a nice, group of patients, some less than 50, some older than 65. In fact, a quarter of the patients were older than 65. So included a lot of patients that may have not been eligible for transplant in the past. Most myeloma studies show there's a slight predominance of males, and they all actually had good performance status. If we look at their kind of risk status, about 15% of patients had ISS stage 3 disease, so more aggressive disease, and about 20% of patients had high risk cytogenetics. So this, a quarter of the patients had more aggressive type disease in this study.
And what do we know about the results to start off with? I guess here you have the remission rates, the complete remission rates.
Yeah. So in essence, about 100% of the patients in the quadruple arm responded to therapy. That's so pretty amazing. And high 90s for the patients getting VRD, which is standard. But if you look at the patients who get a deep remission, so that's a complete response or better, it was 88% in the quadruplet versus 70% in the triplet-based arm. So really deep responses when you add a CD38 antibody to frontline therapy. And if you look on this plot, you see that pretty much all categories or subcategories, subgroups of patients did better with the daratumumab added to VRD. Didn't matter sex, age, ISS stage, cytogenetic risk. All patients actually did better when they got the quad versus the triplet.
Yeah, I think a few years ago, we would be happy if we had a 50% response rate in some of the regimens. And here we're talking about 87% complete remission rates. That's remarkable. So,
Agreed.
and what do we know about the durability of these responses?
So the Griffin study showed very similar data. The Griffin, again, was daratumumab VRD, and in that group, the 48 month PFS was just over 85%. Here, the 48 month PFS was 84.3%. So very similar data in a very large, much larger patient population, just showing that this is something that not only can be done in a smaller population, really tight academic centers, part of the Griffin, but a very global effort like this. Really the best data that we've seen with 48-month PFS, 84%. And what we would expect in the VRD arm, the 48-month PFS of about 60 to 70%.
And I guess the rage these days is what is your MRD negativity rate in a lot of these frontline trials, and the FDA may be open to even considering this as a endpoint in the future. I know you were, I think, at the ODAC meeting just a few days ago, trying to convince the issue on the FDA on this issue.
Yeah, I was lucky enough to be selected to be on the ODAC committee, and so was there, and was one of the voting members. And obviously, we voted 12-0 to use MRD as an early assessment point, and that's based on data like these data in front of us. That is, the overall response rate of this is 100%. So you can't really use overall response rate as a means for accelerated approval. If you have 100% responders, it's hard to do better than that. But it'd be really nice to see what the MRD negative rate is. Who has the ultra responses or the best responses to therapy? And if we look at these data on the left side, the MRD negativity for DARA VRD post consolidation, almost close to 60% of the patients are getting MRD negative. That's like a really dramatic and an impressive response rate. With VRD, it was half of that, it was about 30%. And if we look at overall MRD negative throughout maintenance therapy, et cetera, 75% of the patients are achieving MRD negative at 10 to the minus fifth. That's our standard IMWG criteria for MRD negativity. If we look at a more sensitive line for MRD on the right, 10 to the minus sixth, and if we look at overall, it's 65% of the patients are getting MRD negative at 10 to the minus 6 versus 30% in VRD. Really amazing responses to frontline therapy. And we think that this early MRD assessment will predict for a longer PFS. And we'll see, it's really hard to do OS, overall survival advantages, in frontline therapy these days, because I think survival depends on what people have access to after frontline therapy. Most patients are getting 3 to 5 to 7 next lines of therapy. And so the access becomes very important. If you have access to CARs and bispecifics, et cetera, you're going to have really good overall survival. Here you show the overall survival curve. So pretty dramatic that these overall survival curves are so impressive out, more than 4 years, and patients are 90% or above overall survival.
So obviously the Perseus study was at the late breaking abstract session, but at the plenary session, we had the Iskia study. We'll go through this and then we'll sum up at the end what your takeaways are and how you're incorporating this going forth into your treatment practice when we have both the studies discussed. So can you tell us about the Iskia study?
Yeah, so isatuximab is the other anti-CD38 monoclonal antibody. It differs a little bit in daratumumab in terms of the way it causes myeloma cell death. The big difference is, in my mind, that it causes apoptosis, direct apoptosis without cross-linking. And honestly, we've tested this at UCSF preclinically more than 10 years ago. We think that isatuximab actually combines quite well with carfilzomib. And so we've always been a fan of isatuximab with carfilzomib-based regimens. This was another EMN study. That the Perseus study was also an EMN study. The EMN had really important data at ASH this past year. So in this study, patients were randomized to a different four-drug therapy, isatuximab, carfilzomib instead of bortezomib, lenalidomide and dexamethasone, versus carfilzomib, lenalidomide, dex. So it still is a quad versus a triplet, but using ISA instead of DARA and carfilzomib instead of bortezomib. And in this trial, the primary endpoint was the achievement of MRD negativity. So this, again, transplant-eligible, newly diagnosed myeloma, age less than 70. And these patients were randomly assigned to the triplet versus the quadruplet-based therapy. They all then went on to, that was induction, 4 cycles of induction. They all went on to stem cell mobilization with Cytoxan and transplant, and then 4 consolidation therapies post-transplant. And then what they called light consolidation, which was 12 cycles of KRD in the triplet arm or 12 cycles of ISA KRD in the quadruplet arm. And they checked MRD by bone marrow biopsy and next generation sequencing after induction, transplant, consolidation, and then the light consolidation.
And what have you got to say about the demographics in this study?
So it was very similar to the Perseus study. Again, always a slight male favor, males a little bit more than females. In terms of the high risk, again, about 20% of the patients had high risk by cytogenetics. They looked at ultra high risk. So we're classifying high risk now in myeloma based on the number of high risk cytogenetic abnormalities. So 2+ high risk cytogenetic abnormalities, which we think is really ultra high risk, at about 10% of the patients. And the revised ISS was about 7% of patients in the arms. And so this was, again, a standard newly diagnosed myeloma patients with, it was a minority, but a significant number of patients with ultra high risk or high risk disease.
And what did they see?
So the primary endpoint, like I said before, the primary endpoint was the achievement of MRD negativity. And this was post-consolidation. So on the left side, you see the MRD negativity by next generation sequencing at 10 to the -5th. In the ISA KRD, it was 77%. In the KRD, it was 67%. And this was statistically significant. I'll point out that KRD is, in my mind, it's a really good regimen. That triplet is a really good regimen for transplant eligible population. And we used to use that actually as our preferred regimen in high-risk patients. We'd use carfilzomib, lenalidomide, dexamethasone. But when you add a CD38 antibody to it, it actually improves the MRD negativity in a significant fashion. If we look at the right, if we look at that 10 to the -6, the difference is even more significant. 67% of patients post-consolidation are achieving MRD negativity at 10 to the -6. So pretty impressive how deep the remissions can get with this 4-drug combination.
And it seems like things got better over time.
Yeah, so if you look at each step where they tested MRD negativity, the responses get better and better and better. I call it, this is our typical thing, the US stuff, more is always better. And so in myeloma, in most studies, we have shown that more therapy always seems to produce a better outcome. And so those patients, continuing on to transplant, continuing on to consolidation, always have deepening of their disease. burden or improvement in their disease burden. And I am a fan of doing consolidation post-transplant as well as maintenance based on these data.
And obviously, even in the high risk population, I guess it really stood out.
Yeah, so as you show on this slide on the far right, if we had very high-risk patients in the quadruplet arm, they had the achievement of MRD negativity of 77% versus these truly high-risk, two or more high-risk cytogenetic abnormalities of only 27% in the KRD. So a big difference in the CD38. And, I do think I'm seeing more and more patients these days that are treated in this fashion prior to getting referred to our center for stem cell transplant. More patients are getting quadruplet-based therapy, and some centers are using isatuximab, especially in the high-risk patients.
So obviously, you must be very gratified because you're the one who started the journey with isatuximab, the very first development, the first phase one study. So this is something you must be happy you've brought so far from inception.
We were very lucky to be associated at UCSF with Sanofi in a combined effort to try to bring drugs to fruition and to approval. And so we started way back in 2010 working on isatuximab. And in fact, we had the first responder at UCSF at 1 milligram per kilogram. And that is when we knew the drug was going to be a good drug. And we actually did published the first data on ISA plus carfilzomib, and that led to the IKEMA trial. And then now we have all these important frontline studies, which are just awesome in my mind. And yes, I think these are practice-changing data.
So kudos to you. So just before we wrap up, so how are you now treating your transplant eligible patients? What's your induction?
So for the CD38, combination, the ease of administration of subcutaneous daratumumab makes it, in my mind, an easier drug to give in frontline therapy. So we're giving everybody quadruplet-based therapy. It is CD38 plus VRD as frontline therapy. I would say if we know up front that the patient has double hit myeloma or even, worse, high aggressive disease, plasma cell leukemia, et cetera, we are considering isatuximab, carfilzomib, lenalidomide, and dexamethasone as the frontline therapy. We do 4 to 5 cycles, basically depending on how fast we can get them to transplant. Then we do a single autologous transplant. We will do two cycles of consolidation to at least complete 6 cycles of the quadruplet-based therapy, and then go on to maintenance-based therapy, typically with CD38 plus lenalidomide, or if they have really high risk or double hit, we might actually do the triplet combination for a more prolonged period of time, 6 or 12 months. So this has basically changed our practice, and I do think the prediction is that the PFS from frontline therapy is going to breach more than 6, potentially 7, or maybe 8 years of PFS after frontline therapy. So, I might be retired when I start a patient on tomorrow. I might be retired by the time they've, passed their first PFS, which is pretty amazing.
It is amazing. And so what are you doing for maintenance these days? How do you approach your maintenance?
Yeah, so we were early adopters at UCSF based on the Griffin study. The Griffin study gave patients daratumumab and lenalidomide for 2 years of therapy after their induction, transplant, consolidation, and then 2 years of dara lenalidomide. That's generally how we're doing at the current time. The difference between Griffin and Perseus is Perseus continues daratumumab until progression, unless they were MRD negative and now they're stopping at 2 years if they're MRD negative. We basically don't know the outcome of that next move, that next change when patients are MRD negative. So we actually do 2 years of maintenance dara lenalidomide in majority of patients, and that at the 2-year mark, we'll then decide based on their clinical scenario, their side effect profile, and their MRD result what they'll continue on therapy or if they continue on therapy. We might stop it at completely at 2 years. So we are doing that. Truly in the the really high risk patients, I do like the MUC9 study out of the UK, where they actually give prolonged 3-drug maintenance-based therapy with a CD38, a proteasome inhibitor, and an IMiD. And if they have very high risk, we will do that as maintenance-based therapy.
So you were again one of the pioneers among adopting MRD post-transplant. So this is the last question. So what time points are you checking MRD, and how are you using that data?
Yeah, so MRD, I think, is an important piece of the pie that you utilize to assess what you're going to do and recommend for therapy. We say we don't make changes based on therapy based on MRD. However, when an independent person came to UCSF and reviewed all our data, and we have MRD data on over 500 patients going through transplant, about a third of the patients, when they got one of their MRD results back, we made a change. Either we stopped therapy or we added therapy or we changed therapy in some way, shape, or form. So it is actually part of the pie, and we do utilize it, in fact, unbeknownst to ourselves that we're using it, but we do. So we check it actually we usually check it pre-transplant. So at the bone marrow biopsy that patients have before they go to transplant, we check it at the 2 to 3 month post-transplant bone marrow biopsy, the 1 year post-transplant bone marrow biopsy. And then most patients will agree and want to know their MRD results yearly thereafter. So that's typically our schedule.
Well, Tom, I really appreciate you taking the time and educating the audience on these 2 studies and how it's informing your decision making. I hope that I can reach out to you for a future discussion again, and can't thank you enough for being here today.
No problem. Thanks for having me, Ravi, anytime in the future.